Welcome, everyone. My name is Dave Greenwald, and I'm the co-chair of the National Colorectal Cancer Roundtable's Public Awareness Task Group, which I'm fortunate to co-chair along with Angie Davis, who's the president of Fight Colorectal Cancer and also a longtime Roundtable member. Mostly, we want to thank everyone for joining us today. The 80 by 18 campaign is in full swing. As many of you know, we've had incredible response to this webinar, and it thrills me to see all that momentum that I just described a moment ago. So what is the purpose of the webinar today? The purpose of the webinar today is to share an update of our resource, the 80 by 2018 Communications Guidebook, Recommended Messaging to Reach the Unscreened. We, as a group, are extremely pleased to be able to share our new companion guide, which also features colorectal cancer messaging specifically tested with Hispanic audiences. All of these resources can be found on the Roundtable's website, which is nccrt.org. The guidebook released last year was based on market research and strives to answer the question, how are the unscreened different from those who've already been screened? And what will it take to move them to action? A big question. It turned out to be one of our most popular tools. In fact, it was downloaded over 2,200 times and was highlighted in our 80 by 18 partner survey as our most useful resource in the 80 by 2018 effort. So as you can imagine, the NCCRT is very proud of this guidebook. But we heard a few things consistently from all of you about how to make it better. You wanted more templates and more resources. You wanted localized information, sometimes customized information, and perhaps the request we heard most often was that you wanted to hear about market research that was tested in other languages, including Spanish. There are 272 of you on the call right now. During today's call, Mary Doroshank, director of the National Colorectal Cancer Roundtable and our hero, will give you a quick recap of how the guidebook informs our overall strategic effort to achieve the 80 by 2018 goal, and will highlight some of the new assets in the updated guidebook. We will spend the bulk of this webinar, the time in our webinar, hearing from Ricardo Lopez, president of Hispanics Research Incorporated, who will review the findings from our market research conducted with bicultural and unacculturated Hispanics. And finally, we will close with demonstrations of tools that will help you customize your materials for your local audiences. We really hope these presentations will help you think about how you can use the new messages and research in your own creative ways. And that is an important caveat. The resources in the guidebook are not intended to replace any partners' outreach efforts on their own around colorectal cancer screening, but instead, the NCCRT hopes that these resources will supplement your current efforts and magnify our collective voice with these crucial audiences. Okay, a couple of housekeeping items before we get started. Just so you know, we are recording today's webinar, and the replay will be shared with all of you in the very near future. We also, as always, ask for your help in evaluating the webinar. You'll be getting an email with a survey link, rather. Please help us out with specific feedback as to what went well and what you think we could do better. Finally, because of the large number of participants, all participants are muted on this call. Having said that, we want to make sure you get what you need out of this webinar, so we encourage you to ask questions by submitting them through the webinar. We will be done with the presentations by 1 p.m. Eastern Standard Time, but our presenters will stay on the line to answer any questions. And as always, you can email questions after the webinar. Lastly, if you registered before Monday for this webinar, you already received a copy of the slides and links to the new resources. We will resend these slides and links after the call so you can download these tools and use them in your colorectal cancer control efforts. And so with that, I'm going to turn the program over to Mary Doroshank, who, as I said, is the director of the National Colorectal Cancer Roundtable, who will give us a recap of how these resources fit into the overall 80% by 2018 strategy. Mary, take it away.
Great. Thank you, Dave, for that very warm welcome. And I echo Dave's thanks to all of you for joining us this afternoon. And Dave, are you able to pass the baton to me? Hover over my name and right-click. There we go. And, you know, we are really grateful today because we have quite an eclectic group joining us today. We've got, you know, many Roundtable members who've been active in this issue for a long time. We have new 80 by 18 partners. We have many American Cancer Society staff joining, and we also have CDC grantees. So hopefully most of you are familiar with the National Colorectal Cancer Roundtable, but for those of you who aren't, I wanted to let you know that we are a coalition that's supported by the American Cancer Society and CDC, and it's really everybody you can think of who you'd want at the table to be a part of these efforts to increase screening rates. We have federal agencies, state health departments, medical professional societies, survivor groups, state health departments, just a wide range of groups all collectively working on this shared goal to increase colorectal cancer screening rates. And typically the way the Roundtable does its work is that our members come together to share their expertise and produce different tools and resources, including the one we're going to be sharing with you today. And some of these tools I encourage you to check out, ncrt.org. It's everything from how you do systems change at a practice level, how you implement quality screening. We've addressed policy issues and evaluation questions. And as I mentioned right now, we're going to be focusing on this question of how do we move the unscreened to action. So I wanted to back up just a little bit and talk about our 80 by 18 strategic plan and how this tool fits into that effort. I know you can't read this, but we spent a good part of 2014 developing it, and there are really 4 key action items in our strategic plan. One is how do we move consumers to action, a very important question. How do we help support systems change? So how do we work with health insurers, employers, hospitals, primary care practices, community health centers to get people to take action on screening? How do we address policy barriers? And then how do we keep our momentum high and evaluate our efforts? So I am not going to go over these 10 steps of our strategic plan in detail, but you will find a wonderful presentation by our chair, Dr. Rich Wender, where he goes over these 10 steps in greater detail on our website. But you can see as you look through these, everything from helping to empower clinicians, insurers, employers, helping to reach the newly insured, how to help those folks who are insured but are procrastinating for whatever reason, how do we reach people from low socioeconomic backgrounds. All of that ties into good and effective messaging. So because of that strong need, we worked very closely with the American Cancer Society to conduct some market research in 2014 that we ended up using to produce this Communications Guidebook. And the way the research worked is that we talked to over 1,000 unscreened individuals to understand what were their barriers to getting screened and what did we think were the messages that were going to move them to action. And I definitely encourage you, if you've not already done so, to check out our Communications Guidebook. It goes into this research in much, much greater detail and can really give you a good idea of some recommendations for reaching priority populations. But in a nutshell, what our 2014 market research found was that some of the big issues, number one was affordability. So people had the impression that it was that they weren't going to be covered for screening. Colonoscopy has a reputation for being a very expensive test, and so that access issue was front and center. We also heard from a lot of people who felt that screening didn't apply to them, either because they didn't have symptoms or they didn't have a family history of the disease. Many people had actually never really seen a cancer battle up close, so it was easy for them to procrastinate. We also heard about negative perceptions about the test. So people thought it was invasive, expensive, embarrassing, so the test itself also served to act as a barrier. And then many of you in public health will not be surprised to learn that we still struggle with how to work most efficiently with primary care to make sure that primary care is helping to reinforce these messages. This was a particularly big issue among African American and Hispanic populations. So based on that deeper understanding of barriers, we identified 5 priority audiences, and these 5 audiences are the newly insured. So these are the groups this is the group that we think of as sort of the low-hanging fruit. They've perhaps not had access before, but now they do. How can we help them act on this newfound access? The rationalizer procrastinator. So these are individuals who on paper should be getting screened. They have insurance. They sort of have some awareness with screening and know what they need to do, but yet they're still not acting. And then finally, the economically disadvantaged. As we know, the Affordable Care Act did remove barriers to screening for some, but particularly in states where we do not have Medicaid expansion, this is a bigger size of the population than we would like it to be. And then, of course, there's overlap between these 3 groups, and then running through each of these 3, we've prioritized Hispanics because of their low screening rate and African Americans because of their higher incidence and mortality rate. So based on all that research, we came up with 3 key messages, and they are on the screen in front of you. But the first one is that there are several screening options available. Talk to your doctor about getting screened. This, we think, resonated because it gave people an option if they were concerned about affordability, if they were concerned about the invasiveness of the test. There was something that they could do in the privacy of their own home to get screened. The second message that resonated the most was that colon cancer is the second leading cause of death, yet it could be prevented through screening. And we think this message worked because you can't avoid the fact that it is a leading cause of cancer death, that is something that could happen to the target audience, and yet we gave them a way to address the issue. And then finally, the issue about finding affordable testing options tested very well with our key audiences as well. So then what we did in our guidebook is that we gave all this research and all these messages out to our partners, you on the phone today. And it was so fun for us to see all the different creative ways that these messages were put to use. You Gen Xers on the phone will appreciate that Luke Perry is almost 50, and it really tickled me to hear Luke Perry using some of the tested messages in his PSA about colorectal cancer screening that he did for Fight Colorectal Cancer. Additionally, there's a wonderful resource out by GW Cancer Institute in which they created a social media toolkit based on our tested messages about communicating around colorectal cancer. It's a great resource, and they just updated it from 2016, so I encourage you to check it out. And then finally, this is a landing page that Healthcare Service Corporation put out where you could actually go in and generate reminder messages for patients. And on this website, it actually incorporated some of our tested messages. So that's just one example of how we saw health plans, insurers, employers, survivor groups, other partners putting these messages to use, and we hope you all continue to do so. So, as Dave said, we don't want to rest on our laurels, and we wanted to continue to make the guide better. So in this 2016 update, you're not going to see radical changes, but you will find new templates and collateral. So we added TV and radio scripts for PSAs using our tested messages. You'll have sample letters that incorporate that tested messages from CEOs or leaders from hospitals. We also feature some ways to customize these messages into your local communications, and we've worked behind the scenes with our partner MEO to make sure that those tested messages are now accessible through their online platform. And MEO, our friend Balaji Galio, excuse me, Balaji, if I'm mispronouncing your last name, is on, and he's going to walk us through exactly how you use that online resource later on in the call. We also heard that all of you wanted to have more state-specific tools and data. We know that 80 by 18 is an effort that's really being fought at the local level, and so you need that local information about screening rates, about incidence and mortality rates. And so we do include more specific charts that highlight state-by-state data, but I think what is most exciting is that just recently the ACS released or unveiled a new online statistics center where you can actually go in and create customized graphics and charts based on your needs and your state. And we're lucky to have Becky Siegel on the phone who's going to show us how that works at the end of the call. And then finally, more resources about 80 by 18 itself. We have more press releases in here, template press releases, so you can celebrate your success along the way. We also have added to our collection of tools that tell you how you can work with different partners in the 80 by 18 effort. And then finally, where we're going to spend the bulk of our time talking about today is our new companion guide. And my colleague, Angie Davis, is going to talk a little bit about why this was an important focus of the task group this year. Angie?
Great. Thank you, Mary. That was a great overview showcasing the depth and breadth of the work that NCCRT has been doing. Now, I know we're all eagerly wanting to hear about the new companion guide featuring recommended messages about colorectal cancer specifically for Spanish-speaking audiences. As Mary mentioned, unscreened Hispanics are one of our priority populations in our 80% by 2018 efforts, and for a very good reason. Colorectal cancer is the second leading cause of death among Hispanics, and Hispanics are also one of the populations least likely to be screened for colorectal cancer. Nationwide, 1 in 3 adults between 50 and 75 years old are not getting screening tests as recommended, but among Hispanics, this number is closer to 1 in 2. This fact, along with the size of the Hispanic population in the U.S., makes it important to understand and address this group's unique barriers to colorectal cancer screening. The market research conducted in 2014 profiled Hispanics, but it was limited at that time to English speakers. For this reason, this past year, we invested in market research with bicultural and unacculturated Hispanics. We're very fortunate today to have Ricardo Lopez, President of Hispanic Research Incorporated, review the research and recommendations with you all today. Ricardo, we are looking forward to hearing your presentation.
Well, thank you. And let me welcome you, and I'm going to go very quickly through all of these findings. It was a very exciting research project, one of my favorite. And part of that is because not only were we gathering information from people, but they were also learning from us. We were opening their eyes, which was fantastic. Let me go quickly through what we got from the participants in this study. We talked about health, and we asked them what do they think about health, and they said that, you know, they care about their health. Now, the problem with that is that they don't always know too much about it. They don't know where to get the information, because where they get information from often is from their grandmother, who tells them, you know, what's important and what supplement to take and things like that. So they get, there is a lot of care, but a lot of misinformation as well, and they don't know how to go about getting that information. They tend not to go to the doctor unless something is wrong. That's something that we heard over and over again. Well, I don't have to go if I don't feel, you know, that there's something wrong with me. Why should I go? They're always working, especially the unacculturated newer immigrants. They're always working for their families. They're working very hard. They sometimes have 2 jobs. They don't have the time to do much else, and they think they're doing the right thing, and they think they do what is good for their family in terms of health, but in reality there's a lot of things that they're not doing, especially when it comes to preventive health. They fear medical procedures. They fear the unknown. And part of the fear of medical procedures has to be with the unknown. There's this fear of death. Something is going to happen. And that fear, it's affecting anything that has to do with healthcare. They are very bound by faith. Religion plays an important role. And part of that, you know, delays seeking medical care, because we hear a lot of, you know, God willing, you know, well, what it is, you know, you know, God is going to protect me. I pray every day, and that type of thing, you know, all positive, but at the same time, they are not being diligent in terms of paying attention to preventive medical care. They rely a lot on home remedies. And that's wonderful as well. It's great. A lot of the home remedies work well, but when it comes to the point that they are saying, you know, they're paying attention to a relative who is saying take aloe, you know, to clean your colon, and you don't need a colonoscopy, that's, you know, that's going in a different direction. They can, however, be persuaded by friends and relatives, because family is so important. So, you know, if especially with the younger generation tends to be more acculturated, more informed in terms of health. They are actually persuasive in the Hispanic community. They also had perceptions about, specifically that we asked them about cancer screening and cancer in general. There is an issue with the relationship with doctors, again, especially with the unacculturated, because they remember relationship with doctors as being different in their country of origin. And they feel that a lot of times they don't have the same type of relationship. And part of it is because they see the physician as cold. They're looking at their computer. They're not looking at them in the eye. They're not connecting at an emotional level like Latinos usually want to connect. And that lack, if that doesn't happen, they lack the trust, and the trust leads to them not paying attention, which is problematic. They view cancer screening logistics as a barrier, and by that we mean that, to them, because they don't understand that it is that important, all of a sudden, the fact that they have to take a day off of work, that's a big problem. That's a barrier. That's something that is a hassle. They have to prepare for a colonoscopy the day before. That's crazy. I don't have the time for that. I have to find a babysitter for my kids. My husband has to take off from work if I'm the one, getting the test because they got to drive me. All of these logistics become a barrier, mainly because they don't have that understanding. They also view cancer as a source of fear. We talked about fear and the fear of death. Cancer is very much in their mind related to death. And all of a sudden, cancer is, when we mention cancer, that's a big, big source of fear. They have low awareness of colorectal cancer. As a matter of fact, there's a lot of confusion out there. Some of them say, oh, is that the same as prostate cancer? They don't have a lot of information about what it is. A lot of them don't even know what a colon is. We were talking about it, and it's like, well, colon, but I'm not sure what that is. So there's a very little awareness of colorectal cancer, which, by the way, they call it colon cancer, not colorectal cancer. That's something that we found out as well. And they also have very little awareness, of course, of the screening test, because they don't, even those that know a little bit about colorectal cancer, they don't know too much about what the screening tests are all about. When it comes to barriers, what is it that is preventing? Number one, what I've been talking about, the lack of information. They don't have information about healthcare, and that in itself is a barrier. The fear that we talked about, especially the fear of the unknown, they hold them back. They don't get screened because they are afraid of the procedure. They're afraid of the results. They're afraid of what it may say. That fear is holding them back. Affordability. We found out that, once everything is understood, many of them said, hey, I'll figure out a way if something is important. But affordability is definitely a barrier because of many in the Latino community are lower income, and that becomes problematic, especially if they don't have health insurance. The machismo is real. Machismo is out there. For the men, that is a big deal because anything that is health-related, and especially if it has to do, hey, people say, if it has to, nobody's going to see down there in my private area. I mean, I can tell you that's what we heard, and it was consistent throughout, and that was why they were not getting screened, and that's the reason they gave, many of them gave. And even the woman talked about their husbands using that as a reason, and says there's no way anybody is going to convince him to get tested. No knowledge that colorectal cancer screening can prevent colorectal cancer. Very big, because they don't know that it can be prevented, and if they knew that, many of them told us later, hey, now, it becomes top priority, but I did not know that. And the doctors are not explaining the need. If they're explaining it, they're not being effective. It's not coming up, and this is what the people are telling us, that the doctors are not telling them that they really need to get screened. So when we talked about screening options, we gave them some options, and we said, hey, what do you think of this? The fecal exam, the FIT test, that for them was easy. I mean, it's not difficult to convince them. It's easy, it's affordable, it's not scary, it's convenient, it's effective. The colonoscopy was seen as the most comprehensive because it removes the polyps, and they think, hey, that's, if I'm going to get this done, I'm just going to make sure that everything is right. So these two are, the perceptions were positives on the test. The colonoscopy for them was scary, but they saw it as a complete solution, and once they understood what it was, most of the participants said, hey, I would definitely get tested. Let's go through the recommendations in terms of reaching this audience. First and foremost, the statistics. One of the things we mentioned is, colon cancer is the second leading cancer killer among Hispanics and Latinos in the U.S. Wow, it opened their eyes. It was like, I did not know that, because everybody would mention lung cancer, and they would mention, breast cancer even, and things that are in the media that they think about, but colon cancer is not something that comes to mind. They were not aware of this. They felt that it was essential. Any statistics is something that grabs their attention, and they're going to pay attention to that. We need to explain that colon cancer can be prevented. As I mentioned before, this is key. I had a situation myself. I can tell a little story that I went to a doctor. I was myself avoiding a colonoscopy for the longest time since I turned 50, and it wasn't until this doctor explained to me what it was that I was able to understand, oh, wait, because he said, it wasn't not you're over 50, you have to do it. There was much more to it. So learning, where the participants get that information that can be prevented, that is big motivator factor. Tell people that colon cancer does not need to have symptoms. Same thing. Most Latinos we spoke to, only go to the doctor when they have symptoms, and that's what they told us over and over again. So not having them know that, it's a big motivator. Use strong visual stimuli when communicating with Latinos. They told us this over and over again. Language is often a barrier, especially medical terms, medical information is a barrier. But having these pictures, these visuals that are, some of them, the more gross, the more motivating it seemed to be. And it was not because they really understood what the colon is, but it was like, oh my God, something is going on in there. I got to pay attention. What is this? What are they showing me here? And the picture drove them to try to understand what that was all about. Pictures are easy to remember. Visuals deliver also an emotional response, and Latinos react at an emotional level more often than not. Using firm, clear language. I started telling the story about when I went to the doctor and he was trying to convince me. One of the things that he said to me was like, wait a second, you have cancer in your family, and, he was trying to be firm, and he went as far as saying, well, I don't think you have a choice. You have to do this. Are you going to do it? I said, yes. He goes, okay, let me text. He pulled out the phone and texted his GI doctor, his partner, and he says, okay, he's going to give you a call. I mean, that was like as serious as could be. He's just making the step. Now, not every physician is going to do that, but taking action, and that's what people need. It's like a little push. It's like, no, this is that important. Using fear and guilt, is something that participants told us work very well. So messages that are persuasive. And I'm talking about caring in a way that a loving person cares, about another loving person, not a sales pitch. I mean, if it comes strong like a sales pitch, people are going to dismiss it. In fact, people told us if you say, hey, if you don't do this, you're going to die. If you eat this, you're going to die. People say, hey, I hear that all the time. That doesn't work. That's not what I'm talking about. But being firm with a lot of backup and coupled with hope, it has to have this thing, hey, look, you get this done, you're not going to get sick because we're going to figure it out early, et cetera, et cetera. The messages also have to be personal. They have to appeal to the Latino emotion. They want to have someone that is touched by the disease to deliver the message, and that's something that we heard over and over again. Use family as a motivator. Family is huge in the Latino community, so use the family and their role in the family. Participants told us all the time, hey, if you put it in that way that I got to be there for my family, that is going to, get me to go, but otherwise I may not. And use a trusted spokesperson or known celebrity to deliver the message, and they gave us a lot of ideas. This is qualitative, so these ideas, that doesn't mean that these are the people to get or anything like that, but people like Jennifer Lopez and Salma Hayek and things like that, they always named celebrities that, you know, people would pay attention to. I don't know about Big Papi over here, but let me go on to the next slide. The community may be a powerful avenue, definitely. You know, go through the community. The Latino community, they listen. They listen within their family, they listen in the community, their neighbors, their friends. Word of mouth is extremely important and influential, and all of that can be used to our advantage in getting the word out. Use television. Television is huge in the Latino community. Novelas for the females, the sports for the males. But everybody seems to watch as a family as well, so that happens very often. The bicultural Latinos, they watch both in English and Spanish. In fact, you know, television together with the internet is huge. You know, social media is huge, the community, you know, and everything, you know, radio, newspapers. The more, the better, but mainly the television and the internet are big, big avenues in the community. And then everything else seems to be a little bit secondary. The top messages, these are the messages we tested. We tested a lot of messages, and these are the ones that rose to the top and that really resonated with this audience. Number one, if you're 50 or older, you're at a higher risk for colon cancer even if you're healthy. If you're 50 or older, you're at a higher risk. Don't tell me that I have to get it if I'm 50 or older. Tell me why. Oh, because I'm at a higher risk. Just a few words more than that, and that opened their eyes. Oh, I didn't know that it was because I'm at a higher risk because of my age. Oh, my God, I'm 50. I better pay attention now. As your doctor, you can do a simple test at home. That part of the message also hit home because they always thought it was complicated, so this message did very well. Colon cancer starts with a polyp in the large intestines, and polyps are common in people age 50 and older, but they can be detected and removed before they turn into cancer. Again, we're explaining prevention. Explaining prevention was very big. By the way, the term colorectal cancer screening itself communicates detection and non-prevention. We found that out through this research, that people are saying, well, I didn't know that a screening test would prevent. Isn't that supposed to detect? I thought prevent depends on what we eat and not on anything else. So that was an interesting finding as well. You are so important to your family. Don't let them down. Don't procrastinate any longer. Get screened for colon cancer today. It could save your life. Family, clearly the key motivator here. Don't procrastinate any longer. Do it for your family. Very motivating for Latinos. Colon cancer is the second leading cancer killer in the U.S. among Hispanics, but it doesn't have to be. Start with a statistic like that. Get their attention immediately. Getting screened is absolutely necessary. Talk about being firm. Absolutely necessary. Call your doctor today. And hi, my name is Maria. I lost my father to colon cancer. He was too stubborn to get screened, but the cancer might have been prevented. This was for some of the people. I mean, I had people crying during the research because when they read this, it resonated that much. It was especially effective for those macho types that say, no, I'm not going to get screened, and they had a daughter, and all of a sudden it's like, oh my God, I'm thinking of my daughter. We had one guy in LA that said, I'm walking out of here to go to the doctor. We had some educational content that we also provided as part of this, and the feedback on that was we had a flyer that we presented, and one of the things that we found out through other research is that they wanted everything explained to them. They wanted information. They wanted to understand it, and that understanding was one of the driving forces. This brochure, and it was a little brochure that we just put together at the time, not actually the one I'm showing here, which is the one we're preparing as as part of this project, but similar to this, they read it and they wanted to take it home. They actually, can we take this home? This is that important. That information is what they need. They are hungry for information. And that's, let me see if that's what I have. I want to pass the baton now. That's part of the findings. And Balaji, I think I'm going to pass it to you, right?
You pass it to me, Ricardo. Can you hear me? It's Dave Greenwald.
Oh, Dave, okay. Let me pass it to you. Okay. Oh, I passed it to Balaji already. Balaji, could you pass it to David? I'm sorry.
That's actually okay. Let me just take this opportunity then to thank Ricardo. That was really, really great. It's been a total pleasure working with Ricardo over the past few months on all of this. I mean, when you listen to Ricardo, you feel like you're talking to a friend, because he is a friend. But all of that great stuff also comes along with really strong research, with powerful data, and then with seriously solid analysis. So, you know, on behalf of NCRT, I would tell you that it's been an absolute privilege to work with such an expert as Ricardo, and we've really benefited from the relationship. So thanks, Ricardo. We're going to hear briefly now from our friends at MEO. Mary alluded to MEO at the beginning. MEO is a CDC, NCI-funded group that allows users to customize tested messages to create unique local evidence-based messages. So MEO's been working with NCCRT to allow users to access our tested messages through the MEO platform. The English messages are available on MEO now, and Spanish messages will be available soon. And MEO's database developer, Balaji Gola, and the co-director, Charlene Cabernet, Health Communication Research Laboratory Group, will help give us a quick overview for all of you to learn how to use this new tool. So, Balaji?
Yeah, thank you. I am going to go ahead and share my screen first. Okay. I'm hoping everyone can see my screen. Hello, everyone, again. My name is Balaji Gola, and I have here with me Dr. Charlene Cabernet. We would first like to thank Mary Dorshank and the National Colorectal Cancer Roundtable for continuing to feature MEO as an online tool for creating materials to promote screening. Today, we will do a short demonstration of Make It Your Own, or MEO. MEO is a free web tool for creating small media products recommended by the Community Guide as effective ways to promote colorectal cancer screening and other health behaviors. These products include posters, flyers, web badges, and more. For today's demonstration, I am going to select a poster. Once you have picked a poster, go ahead and click Make It. You will need to give it a name. And click on Go. Now, to the right is a preview area that displays whatever selections you make during this process, and towards the top are all the steps that you can customize in this poster. The first step is where you pick a photo. As you can see, we have a large selection of photos that represent different communities. Now, this could be overwhelming, so you can click on Narrow Your Options to narrow your options. I am going to select for this presentation Hispanic and Latino and female and click Apply. You can always go back and change your options to view different pictures. Now you can click on any of these images to see how they populate in your poster. I am going to select this image, and now that I've selected a beautiful photo, I'm going to my next step where I can choose a message to talk about the importance of screening. As you can see, we have a number of messages, and also we have some Spanish messages too. The little number to the top left of the message, it represents the reading level. For example, this message has a reading level of 5, which means it is the message is at a 5th grade reading level. I am going to narrow my options here to English, reading level 0 to 3, and select a theme of prevention. And click Apply. You can click on these messages to see how it populates in the preview area. And I'm going to select the message, Stop Cancer Before It Starts. And this message happens to be heavily influenced from the messages that were developed by the National Colorectal Cancer Roundtable and tested last year. Now that we've picked a message to talk about the importance, you can select a call for action. This step is similar to the previous step, so I'm going to go ahead and narrow my options again to English and select healthcare provider as the theme. Now, as you can see, this is not specific to a doctor, but healthcare provider in general. And I'm going to select the third message here, and it displays in my preview area. So up to now, all the steps that you've seen are mandatory steps. MEO will not let you proceed without making a selection. The remaining steps are not mandatory, but we recommend that you try and use them so that you can customize the poster to the best of your needs. So the next step is where you enter contact information. This is a place where you can enter a phone number, an address, or a website, or any other information that you like to display. I am going to select a font size of large and enter a phone number. Now, if you have more information, you can change the font size to a smaller size so that it can fit more information. So I'm going to go ahead and click Apply. The next step is where you can enter acknowledgement. Now, this is an area if you want to acknowledge a funder or a grant or any legalese that you like to display on the poster, this would be a perfect place to enter that. I am going to enter a fund number, a grant that funds this process as a sample, and click Apply. The next step is the last step for this poster, where you can upload a logo. As you can see, this poster has multiple options, and these are options for various sizes since organizations have logos of different shapes. I am going to upload a rectangular logo, but you can always upload any other shape. So I'm going to upload a MEO logo for this demonstration. Go ahead and click. And then I can go ahead and click Finish. What MEO does now is it's basically layering your different selections and creating links for you for the user to use. The first link is a PDF, and I'm going to go ahead and click on Download for that. As you can see, this is a larger version of your PDF. It's a high resolution, so it is the best one to use for sending to a print shop or even to your own printer. I'm going to go back. The next option is where you can download a JPEG. This is a slightly lower resolution that you can use for online purposes. You can share your poster using the various social media links that are available. You can also email it to your colleagues using the email link. You can share the poster that you created on the bulletin board. The bulletin board is an area where MEO users can post their products and creations. I would recommend you to visit this area if you're a first-time MEO user. The My Library section is where you can visit to see your product that you've created in the previous visit. You can, as you can see, this product that I just created is also displayed. You can edit your product here, duplicate, share, or delete a product that you've created. Now, the duplicate is a great feature to use if you want to just make very small changes to the poster, like the message or just change a picture, so you don't have to go through the entire process. Now, that would be the end of my demonstration. I'm going to go ahead and stop sharing my screen. So as you can see now on the slides, these are some of the MEO user posters that were and other products that were created. So again, please go ahead and visit meoworks.org and sign up, and also please feel free to use some of the other topic areas that we have on MEO. And that concludes the presentation. I am going to go ahead and pass the control to Rebecca.
Great. This is Angie. Balaji and Shaneen, thank you so much for that presentation. MEO is an outstanding free resource. I've had the opportunity to use it, and it is extremely user-friendly. What you all have created is pretty outstanding. Last but not least, we're going to close with one last demonstration featuring the new American Cancer Society Statistics Center. We know many of you have wanted quick access to state-specific data and graphics. Becky Siegel, the American Cancer Society's Strategic Director of Surveillance Information Services, will give you a short demonstration of this tool. Becky?
Hi, thank you so much, and thanks for the opportunity to share this exciting new tool that we launched a few weeks ago. So my group produces the Cancer Facts and Figures publications and the accompanying cancer statistics article that are published every January. And we released this new interactive site. It has a really user-friendly format. And I'm going to just take a few minutes to give you a brief tour of the site with a focus on colorectal cancer statistics. So here we are at the home page, and you can get to the site either from the Cancer Facts and Figures landing page. There's a link there. Or it's a pretty easy URL to remember. It's cancerstatisticscenter.cancer.org. The home page has just basic information, commonly requested statistics. Here we have estimated cancer cases and deaths in the current year. So you can see where colorectal cancer ranks compared to other cancers. And we all know that colorectal cancer is the second most common cause of cancer death when both sexes are combined. And it's the fourth most commonly diagnosed cancer. So I'm going to scroll down here, and this is just the overall cases and deaths. They're not colorectal specific. Here we have incidence and death rates for the current time period, and maps that show the geographic variation in overall cancer incidence and death rates. And in a minute, I'm going to show you maps specific for colorectal cancer. And here we have long-term trends in cancer death rates in women. And the colorectal trend is in yellow. So you can see we're beginning here in 1930. Colorectal cancer death rates in women have been declining since around 1950. And it's important to note that because disease classification has changed over time, has improved, that these rates here, and you can actually hover and see rates for specific years, but these rates are not going to match death rates for colorectal cancer in the rest of the site because they include anal cancer and cancer of the small intestine that we don't include anymore. So that's an important point to keep in mind. But if we scroll down, you can see the same trends for men. And you see that colorectal cancer death rates also peaked around 1950 in men, but then were fairly flat and didn't start declining until around 1980. So different patterns there. I'm going to continue to scroll down. Here we have the probability of developing and dying from cancer, and 5-year relative survival rates. And these survival rates are sorted based on high to low survival. So if we go over here and expand to see all the data and scroll down, we can find survival rates for colorectal cancer. So for all stages combined, the 5-year survival rate is 65%. I'm going to close out of here. The data on the site are organized by state, by cancer type, and by metric. So I know everyone here is interested in colorectal cancer, so I'm going to go into the colorectal cancer page. And here we have a dashboard that looks very similar to what we saw on the home page, but of course specific for colorectal cancer. So you have the estimated cases and deaths and the incidence and death rates. And we have these by sex as well as by state. And here we have maps showing the geographic variation in colorectal cancer incidence and death rates in the current time period. Incidence and death rates by sex, and then by race and ethnicity. And I know a lot of you are interested in specifically what's going on in your state, so I'm going to go up here and select Alabama. And again, we have a dashboard that looks similar to the home page with information specific to Alabama. Colorectal cancer is also the second leading cause of cancer death in Alabama. That's not true for every state. And then we have incidence and death rates. So I'm going to scroll down quickly because what I want to show you is at the bottom of the page. But you can find incidence and death rates for colorectal cancer for your state. But here at the bottom of all of the state pages, we have screening and risk factor prevalence. So you can see that in Alabama, of 67% of residents 50 and older report being current for colorectal cancer screening in 2012. And that's very similar to the national median of 66%, which is why Alabama falls in the middle in terms of national rank. So that's interesting, but you might like to know, well, that's what I'm doing. What about neighboring states? You might want to see how you're doing compared to other states. So to look at that, we would go to the analysis tool, go into cancer screening, and we're going to select colorectal cancer screening. And here we see, again, the median U.S. screening rate is 66%, but we're interested in data for all the states. So I'm going to select all of the states. And now you can see that Massachusetts has the highest screening rate, is 76%. And if we do a reverse sort, we see that Alaska has the lowest rate at 57%. You can also sort alphabetically. It's easier to find your state that way a lot of times. And you can also view this data in a table. Sometimes it's nice to see a map so that you can see, again, the geographic patterns. And here you can see that screening rates are generally highest in the Northeast and lowest in the Middle South and Middle North states. And I also want to point out that the data source for all of the tables and figures on the site are contained in a footnote with a live link. So you can actually click on the link and go to get more information about BRFSS data that we use to supply the screening rates. So I'm going to go back here. This is interesting, but it might be nice to see maybe a side-by-side comparison of screening with colorectal cancer death rates. So I'm going to go up here and select Add a Metric to Compare. And I'm going to choose Death Rates. By default, this provides me with the overall cancer death rate. So I need to go in here and select colorectal. And now we have a table that shows screening alongside death rates by state. And then if we view this as a map, we have two beautiful maps showing patterns for these two metrics. And it's important to point out, however, that because it takes 10 to 20 years to see the reduction in risk that's afforded by screening in population data, that you would not expect these patterns to be the same, because we have current screening rates and death rates which are reflecting historic screening. And if you are interested in using these maps perhaps in presentation, all of the tables and figures are available as a PNG image. You can download that and pop it into a PowerPoint presentation. All of the data is also available in raw format in an Excel file. And you can share any of the tables and figures on social media. We also have in the About section information that tells specifics about the site, but what I want to point out is an email address here because we're anxious for feedback. If you think there's anything we could do to improve the user experience, we would love to hear about that. So that is pretty much what I have. That's a quick and dirty tour of the site, but we hope that you'll use it. We think it's a powerful tool, and spread the word to your colleagues. Thank you so much.
Thanks, Becky. That was terrific. Actually, the whole thing was terrific. So I wanted to thank all of our presenters, Mary, who gave you an amazing overview, Ricardo, you already know what I think about Ricardo and the work he's done, Balaji and Charlene from MEO, and then finally the graphics from the American Cancer Society, and Becky's presentation now were just awesome. So with that, we held within our time limit. It's actually 2 minutes before 1, which is pretty good. There are 365 of you on the call. We'd like to open it up to questions. A couple of the questions have already come in through the website question and answer, but we'd love some more questions if there are any from the group out there. All of our speakers are available for questions. Do we have anything out there?
Great, and this is Mary. I see a few coming in already, so perhaps work backwards a little bit. But yes, the screening is in 2012 data from BRFSS. We spoke to our colleagues at CDC. They do have the 2014 data, but it is not published yet. So researchers can actually access 2014 screening rates, but they have not yet published it on the CDC website, and I'm told by our friends at CDC that that should happen very soon, in a month or two. So we'll get that up as soon as possible.
One question that came in was, how do we get the booklets mentioned at the beginning of the program? So those will be mailed out, emailed with all of the links and attachments. They were emailed to most of the group that had signed up in advance and will be emailed again. Is that correct, Mary?
That's right. So if you had registered as of Friday, you already received the link and a copy of the slides, and we'll catch everybody else in the next round and make sure that everybody has a copy. But you can always just go to nccrt.org, click on the 80 by 18 button, and you'll, I think, be able to quickly find our new resources.
For Balaji, there's a question that says, are there LGBT options on the MEO site?
Yes, I will let Charlene Cabernet, Dr. Cabernet, answer that real quick.
Hi. Right now we don't have any LGBT-specific options. For very specific populations like this, probably the most limiting factor is the amount of photos that we're able to acquire. So that we've had others recommend this as well. We just haven't been able to get as many photos with this population. If anyone has any connections to a photographer or a group that might be willing to pose for or create models for photos, we would love to hear that from folks.
Thanks very much. Another question about MEO. Can hospitals have access to MEO, and can it be co-branded?
Yes, it can definitely be co-branded, but that would be something that we would work with the hospital on. It would be a one-on-one thing, but the technology and the system is set up to be able to do that. So you can always contact us at the contact link, or the email address is nspencer@wustl.edu. Again, it's nspencer@wustl.edu. And we can definitely work with whoever's interested on this.
Perfect, thank you. Ricardo, a couple for you. Were there any differences in the efficacy of the tested messages with Spanish-speaking only versus English-speaking only, or with bilingual Latinos?
Yeah, the messages were actually pretty much the same in terms of the acculturation level. We find that there were a couple of them, like the ones that were more emotional in nature, as opposed to the more factual. The unacculturated tend to be more on the emotional side, while as acculturation goes on, it's more on the numbers and the factuals and the statistics. But that is a big, assumption there, because overall the responses were correlated very well.
Perfect. There was another question that came in. Sorry. That you, I know that we talked about this a lot in our discussions. It says that you noted that religion and faith could be barriers to seeking screening. Were there any messages related to faith testing with Hispanic audiences?
We had no messages related to faith. Is that what the question was?
That's what it says, yeah.
Yeah, we had no messages specifically related to faith that we tested.
Okie doke.
This is Mary. I will say that where faith came up was as a possible channel, so that did seem to be something that is an opportunity for us. That it's noted in the guide the high percentage of Hispanics that are either Catholic or Christian faith, and that going through respected community organizations and certainly faith-based organizations presents a real opportunity to get our messages across.
Absolutely.
We recall that well. For Becky, so you noted the statistics, and you noted that the source was the 2012 source, and I think the crux of this question is the Web Statistics Center updated more frequently than the ACS Cancer Facts and Figure publications, or any information you can give us on how often that site is updated?
Sure. So we just, this is all brand new for us, and the plan originally was to update all of the data once a year, when consistent with facts and figures. But we have cancer prevention and early detection facts and figures tables coming out in April, and those will contain the 2014 BRFSS data. So I have inquired with our vendor about whether we would be able to update the screening data at that time, and we aren't sure at this point, but we will try.
Perfect. Thanks very much. Ricardo, there was a question during the presentation about the market size, or the sample size rather, for the market research that was done?
Yes. This was qualitative research, not quantitative. In qualitative research, we don't concern ourselves with sample size because we don't project, it's not statistically projectable. We use qualitative research when the purpose is to explore. Anything that is exploratory in nature, we get more insight through qualitative by reading people asking questions. So in essence, if we're going to talk about numbers, we conducted focus groups in 3 markets, Los Angeles, Atlanta, and New York, and we conducted, I think it was, I forgot now the number of focus groups, but there were a significant number of focus groups.
24, Ricardo.
I'm sorry?
I believe
24 focus groups.
24 focus groups, and then we conducted the interviews. But anyway, the sample size question is more of a quantitative question, so in terms of number of people, it wouldn't apply anyway.
And this is Mary, and I would add that we did have our companion guide reviewed by researchers within the National Colorectal Cancer Roundtable, sort of as an added check to make sure that this was aligned with other research people had seen, that it aligned with the literature. We also had some experts from the American Cancer Society review as well. So we felt very good that these themes were grounded in what was already out there, perhaps with a little bit added layer of richness thanks to Ricardo's great work.
Okay, and Ricardo, another one. The question has to do with the focus groups and testing being done around colonoscopy. But how about those who could not afford colonoscopy and would rather benefit from FIT or FOBT testing? And the question is, are there any specific recommendations that the market research came to as to what the messages should be for that group of people?
Right, and it was not just on colonoscopy. We actually explore all of the testing options. It just happens that, you know, participants were mostly aware of colonoscopy. That doesn't mean that they were aware, but colonoscopy is a test that, you know, some people have heard about. So there was discussion on that, and a lot of the fear was linked to colonoscopy, not to the other tests, because the awareness of the other tests was very low. However, the FIT test was one that stood out, and there was a slide on that in my presentation, as one that people really thought was easy and they would have no problem whatsoever. There was no fear associated with that. Some thought it was gross, but there was no fear associated with that.
And I agree. I mean, I think the messages really resonate no matter what testing option is being pursued by the patient. Back to Becky. So you thought doing it by state was good. Somebody wants to know if the data is available by county.
Not currently. We have access to mortality data by county, but we don't have that in the site yet. We were really, the scope was to provide the data that's in facts and figures. So we plan to expand in the future, but we'll just have to see how that goes based on resources and that sort of thing.
Perfect. Ricardo, how did you or we identify the participants for the focus groups?
Yeah, the participants were all screened based on some screening criteria that we decided upon. We wanted to make sure, and this is what we usually do on qualitative research, we wanted to make sure that they are, you know, that they have representation, that we have people there from different acculturation levels, different countries of origin, that it's not all Mexican or all Puerto Rican or whatever, and we had representation that matched certain quotas, that they had not gone for testing before, that they were over 50, that, you know, we selected certain criteria. After that, the way it was designed, we used databases in which we tapped into those databases, called people on the phone, took them through a screening questionnaire, and if they qualify on all of the questions, then they were invited to participate.
Sounds perfect.
And this is Mary. That makes me think we probably should have added in the appendix the screener, and we can certainly do that at a later date. So that's important information, I think, for folks to have. So thank you for the question.
Mary, do you see other questions? I see a lot of wonderful comments about the MEO site and the ACS site and Ricardo's presentation, which we very, very much appreciate. I don't see any more questions that have been typed in. Mary, do you see any others?
Yeah, you may have gotten them all. One thing I did want to mention, and Ricardo and I have talked about this, and we're on the same page. Our external reviewers did caution about guilt and fear in messaging, and that did hold true with what we heard in the focus groups, but both Ricardo and I, you know, wanted to make sure that people understood that that must be done very carefully, and we have some cautions about this within the guide itself, but there are instances where if guilt or fear does not strike the right tone, does not give people enough hope, if it, you know, is done in a way where there's a backlash, it can actually have the counter effect that you wanted to have. So we have some language in the guide that if you are going to rely on those sources, make sure you do pre-testing of your materials, that you evaluate as you go to just guard against that and course correct if necessary.
Great advice. Anything else from any of the speakers for the other speakers?
This is Balaji. I see a couple questions that I just want to revisit. A couple people have asked again how to access MEO, and it's you visit it at meoworks.org, and it's free to sign up, so feel free to sign up. I just wanted to tell you again, it's meoworks.org.
There was a question about whether the ACS logo would be available to use with MEO. I don't actually know the answer to that one.
Well, I guess I mean, you can always upload any logo onto the product wherever we have a logo uploading step. So I don't know if it's a free logo to upload, but if the legalities are all fine, I guess anyone can upload the logo.
And hi, everyone. This is Colleen Fitzwater at the American Cancer Society. And for any of the American Cancer Society staff on the phone, I would suggest that you also take a look at our brand toolkit because we have some various resources in there as well that would have the various messages that have the ACS logo on it.
And there is a question here about return rates for various home kits, and that is something we have looked at in other resources. So this is a project of the Public Awareness Task Group, but we have a very active professional education task group that's actually in the process of writing a new guide on stool-based testing. So I'll see if we can get a specific answer to that question on return rates of take-home kits and get that out to all of you in the follow-up.
Someone asked whether the messages that Ricardo tested have been added to MEO, for example, message E, and a follow-up question about when Spanish will be available.
So we currently have Spanish messages added, but as far as the messages that Mr. Lopez developed, I think we're still working, and a number of the messages are very similar to that. The constraint we have right now is with the size. So we're trying to work and see how it fits on to the space allocated for the template that we currently have.
Yes, and so we have been working with Nikki Spencer, one of Balaji's colleagues, and so we can let everyone know when those messages are available through MEO. It is interesting, though, that the messages that tested better definitely tended to be on a little bit on the longer side. So, you know, that's something that we'll have to wrestle with a little bit to get them in the MEO format.
Sounds good. Any other questions out there, folks? I don't see any. Mary, any other thoughts?
No, this was wonderful. Really, thank you to all the speakers, and thanks for the wonderful turnout from all of you on the phone. Definitely please let us know if you have any other questions or if there's other resources that you need to help you do our work. You know, please let us know. We're always happy to try to fill the needs that are out there, and of course, we learn from all of you as well. So if you have advice that you would like to push out to other partners, you know, we're open to that information as well. So thank you.
And thank you on behalf of us, too, and have a great afternoon. Thanks again so much.